بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. نرحب بكم جميعا في هذا المساء في الندوة الرابعة والتي بعنوان Approach to Patient with Severe COVID، والتي هي جزء من مبادرة امتنان تقدمها الهيئة السعودية للتخصصات الصحية لدعم الممارسين الصحيين لمواجهة الجائحة كوفيد-19 حفظنا الله، والتي سوف يقدمها بإذن الله عز وجل الدكتور ياسين عربي، استشاري العناية المركزة ورئيس قسم العناية المركزة في مدينة الملك عبد العزيز الطبية، والأستاذ البروفيسور في العناية المركزة في جامعة الملك الملك سعود للعلوم الصحية بالحرس الوطني. In English, Assalamu alaikum, welcome to everyone in this evening webinar about approaching to patients with the severe COVID. It will be presented with the Dr. Yassin Arabi. Dr. Yassin Arabi, the intensive care consultant, and he is Director of Respiratory Services and Professor in College of Medicine, King Saud bin Abdulaziz University for Health Science. He is editor in Intensive Care Medicine Journal, and also he adjuncting professor in Monash University in Australia. And I would like to disclose this webinar being recorded before we go live now for speaking, because the speakers cannot be joined with us at this time. And I hope to enjoy this evening webinar. And we're going to collect the question. Maybe we're going to try to answer some and you cannot answer some. Bismillah ar-Rahman ar-Rahim, and نبدأ الويبينار. I want to make sure to clarify 2 points. The first point, you don't need to write to attend. The system is going to capture already all the data that you are attending with us. For CME, at the end of the webinar, the system going to capture the data and we're going to put it in your accounts. You don't need to apply, you don't need to account. Just make sure that the ID, your Saudi Council ID, being entered right in the first time at time of registration.
Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me to give this presentation on management of acutely ill patients with COVID-19. I'd like to thank the Saudi Commission for Health Specialties for this invitation and for conducting this series of lecture. In Arabic, أشكر الهيئة السعودية للتخصصات الصحية على هذه السلسلة من المحاضرات وهذه المبادرة، مبادرة امتنان لدعم الممارسين الصحيين لتصدي لجائحة COVID-10. What I'll be doing in this presentation is I'll be discussing the epidemiology of this disease. I'll cover the clinical presentation and diagnosis, and then talk about aspects of management of this infection, including ongoing studies, supportive therapy, steroids and immunomodulators, some of the information that is emerging about antivirals, co-infection, and the future directions. This is the third pandemic of coronavirus in the last 2 decades. In 2003 and 2004, the world has witnessed the emergence of SARS. Then in 2012 until present, we have cases of MERS, and now we are hit with the largest outbreak, which is the COVID-19. COVID-19 stands for coronavirus disease 19, so this is where the abbreviation coming from, and COVID-19 refers to the disease. SARS-CoV-2 refers to the virus, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. This is called coronavirus because of the shape of this virus that has these spikes called spike protein that gives it the crown shape. The coronavirus family include multiple viruses that infect humans. Some of them, 4 of them, have been known for a long time to cause upper respiratory tract infection. And the pandemic ones, SARS-CoV, SARS-CoV-2, and MERS-CoV constitute the other coronaviruses. So there are 7 coronaviruses that infect humans. Now, this current coronavirus has 75 to 80% genomic similarity to SARS-CoV, 50% to MERS-CoV, and 96% to a bat coronavirus. It uses the same receptor as SARS-CoV, which is ACE2, but different receptor from MERS-CoV, which is DPP4. This is the updated case definition by the Saudi CDC, or Wiqaya. So patient who has acute respiratory illness plus has a history of travel abroad or has visited or resident of high-risk area for COVID-19 in the kingdom, or had a close physical contact to a person with confirmed COVID case, or is working in the healthcare facility. In addition to this, any patient who has unexplained severe acute respiratory illness, whether it's community-acquired pneumonia or hospital-acquired pneumonia, even if these epidemiologic links don't exist, at this time should be considered suspected COVID-19 and should be tested. So this is very important. A patient who has severe community-acquired pneumonia or nosocomial pneumonia, even if there is no contact history, should be suspected of COVID-19 at this time because of the high preclinical probability. This is the most updated map from the WHO, which shows that cases of COVID-19 have been observed around the globe. Almost all countries and territories have cases of COVID-19 to variable degrees. This is the epidemic curve of COVID-19, started in late December, and then in February peaked in China, then slowed down. And then after this, in early March, start to increase around the world. You could see these are the different regions. Europe constitute now the largest daily cases around the globe, followed by the Americas. And in the Middle Eastern is this purple color. It's this one, where there have been cases, certainly not to the same extent as Europe and North America, but it is substantial, giving the scale here. The scale is from 0 to 80,000 per day. So large number of cases daily. So the total cases thus far in the last almost 3.5 months exceeded 1 million cases around the world, with the European region constitute almost 50% of them. America constitute around 300,000, and the Middle East around 65,000 in total. The WHO risk assessment of the situation is very high risk. This is the most updated statistics from Saudi Ministry of Health. As of yesterday, there are 2,179 cases. And yesterday they were reported 140 cases in different regions that are shown in this slide. Now, what do we know about this infection? This infection that affect different age groups, but certainly the highest incidence is an age group between 30 to 79. This is the report from the Chinese CDC. Also, almost 87% of cases were in this age group. On the left side of the slide is the distribution of cases in China. And what you could see that in China, 80% of the cases were considered not severe. So these patients would not normally require to be admitted to the hospital. There are additional 15%, they were severe but not critical. So these patients would normally meet admission criteria to the wards. And there is additional 5% who were considered to be critical. The overall mortality in China was reported to be 2 to 3%, but this is when you take all these cases together. If you take only the non-severe case, the mortality is actually very low, it's 0.1%. But when you talk about the hospitalized patients, it's around 8%. And the mortality among the patients who were admitted to the ICU is around 42 to 62%. So the mortality among the most severe cases admitted to the intensive care unit is substantial. On the right side is what happened in Italy. And what you could see is there's a similar pattern but there are more cases that are considered severe. It's around 25% of the cases were hospitalized to the wards, and the percentage of patients requiring ICU around 5%. And the total mortality case fatality rate in Italy was higher than China's, around 7%. This might be related to the higher age group that were affected in Italy, maybe more comorbid conditions, and so forth. Why patients die from COVID-19? This is a study published in Intensive Care Medicine. Around 53% died because of respiratory failure. Around one third of the cases died because of combination of respiratory failure and myocardial damage, and 7% from myocardial damage alone. So around 40% of the patient have some evidence of cardiovascular failure. Whether this is related to myocardial involvement with the infection or just non-specific myocardial dysfunction remains unclear at this point. This table summarizes the key differences between the SARS, MERS, and COVID-19. The three infections started from a country in Asia. So the SARS and COVID started from China. MERS started from Arabian Peninsula. The three corona infections, interestingly, were related to animals. They are zoonotic infections. SARS was linked to civet cats and bats. MERS is related to camel, and COVID-19 possibly to bats. The three infections are transmitted human to human, although to variable degrees. MERS has a low human-to-human transmission. SARS has high human-to-human transmission, and COVID-19 has a very high human-to-human transmission. There is a common feature among the three infections. All of them can cause nosocomial transmission, and that's why we should be extremely careful when we manage these patients. There is also the three infections share the feature that they can cause risk to healthcare workers. The number of countries affected by SARS and MERS are 26, 27, and they cause cases in the thousands, while COVID-19 has caused more than 1 million cases so far. The case fatality rate for MERS is the highest in total, 34%. For SARS, about 10%. For COVID-19, around 4%. This might be related to the different proportions of patients who were mild versus severe or moderate. So how do these patients present? These patients present, the severe patients come to ICU, present with fever, cough, dyspnea as the most common symptoms. Now, these are the symptoms that you would expect in any patients with pneumonia, really. So these are not very specific to COVID-19. Very often, these patients have comorbid conditions such as cardiac disease, pulmonary disease, cardiovascular disease, diabetes, and so forth. Radiologically, these patients have infiltrates. In China, there were commonly CT scans were used. So in a study that had 975 CT scans done, most of them were abnormal, showing ground glass appearance. However, there is a small percentage of patients who had COVID-19, but they have normal radiological studies. So even in the severe cases, 2.9% had normal CT scan. This is what CT scan of patient with COVID would look like: extensive bilateral infiltrates. So this patient on day 5 has this infiltrate, and with time on day 19, you could see that these infiltrate start to resolve. This is an interesting 3-dimensional CT scan showing the septal infiltrate or thickening and extensive disease on both sides of the lung. Now, this is one study showed that the PCR may be negative initially in patients who have COVID-19. And what is important for us, if we have high level of suspicion for patients for COVID-19, that the test might need to be repeated, especially from lower respiratory samples, preferably. So the diagnosis of this disease is based on doing PCR for SARS-CoV-2, and you can do upper or lower respiratory samples. But in patients who have pneumonia, where the infection is in the lower respiratory tract, it is better to take endotracheal aspirate, sputum, or bronchoalveolar lavage, because the yield will be better than upper respiratory sample. And it is important to repeat the samples when initial tests are negative despite suspicious clinical features. SARS-CoV has been isolated in stool or blood, but the diagnosis really rely on the respiratory samples for all practical purposes. The virus RNA and the PCR positivity continue to be positive for some time after diagnosis. So in one study, the median duration of viral shedding was 12 days. 83% had viral shedding for 7 days or more from the nasopharynx. The pathophysiology of this infection has multiple similarities to other coronaviruses, and this table contrasts this limited data we have so far on COVID-19 from postmortem biopsy with our one case report from our study on MERS patients. What you could see that both infection caused diffuse alveolar damage histopathologically. In our MERS patient, we were able to localize the virus by electron microscopy. The heart in both cases, these are limited number of cases, there were no histologic changes. We found in our MERS patients evidence of myositis, and in fact this photo here from the muscle, and you could see many viral particles, these small round corona shaped particles are the virus. The liver you could see mild lobular and portal hepatitis, and the GI tract in one study for COVID-19 showed evidence of viral infection in the gastrointestinal mucosa. So that's also important from a diagnostic standpoint, but also from infection control standpoint. Patients who come to the ICU, they come with ARDS as or pneumonia as a predominant feature, but many of them have also evidence of hemodynamic instability, shock, acute cardiac injury. Arrhythmia was reported in this study in 44% of patients, and acute kidney injury also been reported with COVID-19. Certainly not as high as observed with MERS. These patients receive different treatments based on sites, but generally, this is from a study from China, where most patients received antiviral therapy. Very often, patients receive steroids. Non-invasive ventilation is used, and some patients received ECMO, and many patients were intubated and placed on intensive invasive mechanical ventilation. So one important thing when we talk about COVID-19 is remember that this infection can be transmitted within hospitals. And in one study, 41% of cases were presumed to be related to transmission within the hospital, 12% among patients hospitalized for other reasons, and 29% among healthcare workers. In a study from China, 3.8% of cases of COVID-19 were among healthcare workers. The percentage in Italy was higher, was 7%. And unfortunately, this led to several deaths, and we hear about this all the time among healthcare workers who treated patients with COVID-19. And that's the infection control precautions need to be very strict. And at this point of time, suspected and confirmed cases should be managed in negative pressure room with a strict compliance with hand hygiene and standard precautions, airborne and contact isolation for ICU patients, and proper use of PPE, and very important to follow airborne precautions when performing aerosol generating procedures. For example, endotracheal intubation, non-invasive ventilation, tracheostomy, cardiopulmonary resuscitation, manual ventilation before intubation, and bronchoscopy. So the mainstay for management of COVID-19 is supportive care at this point. And I would like to refer you to several documents that discuss this topic. There is the guidance from WHO, which I was privileged to be part of it. We had a review article on management, critical care management of community-acquired severe respiratory viral infection in intensive care medicine. And recently, the Surviving Sepsis Campaign guidelines, which was published simultaneously a few days ago in the critical care medicine and intensive care medicine. And it is a joint project of the European Society of Intensive Care Medicine and Society of Critical Care Medicine in USA, which I was also privileged to be part of it among several of esteemed colleagues. And this slide, which you could download from the SCCM website, has a summary of recommendation for managing patients with COVID-19. What we need to do if we intubate patients who have mild ARDS is to follow a lung protective strategy with tidal volume 4 to 8 ml, look for possible co-infections, keep oxygen saturation between 92 to 96% and avoid hyperoxemia, consider conservative fluid strategy, consider empirical antibiotics. We're not sure about corticosteroids, and maybe there's, we'll talk about this, there may be harm in some patients. Patients who have severe ARDS maybe use higher PEEP, use neuromuscular blockers to boluses to facilitate ventilation, but no need for infusion. You could use traditional recruitment maneuver, but avoid staircase recruitment maneuver, prone positioning in severe cases, maybe in certain selected patients, steroids. We'll talk about this debate. And there are the discussion about the antivirals that I'm going to discuss at this point in a minute. So in a patient who have severe hypoxia and has indication for, clear indication for endotracheal intubation, then I think you should proceed for intubation. Get somebody who is expert to do the intubation, so to reduce the number of attempts, use airborne precautions, and minimize the number of staff in the room. Consider using video laryngoscope, in this case, to reduce the number of attempts and to reduce the close proximity of the face to the patient face. If the patient is tolerating supplemental oxygen, maybe some patient maybe benefit from high flow nasal cannula. If non-invasive ventilation is considered, it should be monitored closely and short period of time. And it is important to avoid delaying intubation if the patient is worsening. So where is this information coming from? There are data about non-invasive ventilation in critically ill patients with MERS-CoV. This is a study where we had 300 patients with MERS. Around 1/3 of them had been treated with non-invasive ventilation. What we observed that the failure rate is very high, is about 92%. And those patients who were failed were likely to be more hypoxic and require inhaled nitric oxide. So the use of non-invasive ventilation was not independently associated with 90-day mortality. There are also studies from SARS and influenza also showing that the failure rate can be very high with non-invasive ventilation. And therefore, the Surviving Sepsis guidelines suggested that maybe if you want to use, maybe start with high flow nasal cannula over non-invasive ventilation. And if it's not available and there's no clear indication for intubation, maybe a trial of non-invasive ventilation with close monitoring. But if the patient worsens, then you should proceed for intubation without further delay. In our colleagues in Italy, they're using a lot of helmet non-invasive ventilation, which reportedly to be successful, but data is being awaited. So the Surviving Sepsis Campaign could not make a recommendation about the use of helmet non-invasive ventilation. Of course, I think it's important to keep in mind that high flow nasal cannula and non-invasive ventilation have a potential risk of aerosol generation and possible transmission. So if they are used, they should be used within a negative pressure room, as illustrated earlier. ECMO, the data on ECMO in general ARDS patient, the best study we have is the EOLIA trial, which showed that there was no statistically significant difference in mortality, although a post hoc Bayesian analysis suggested that it might have some benefit. Also, observational data from influenza suggested benefit of transferring patients to sites with ECMO centers. This is data from Saudi Arabia from MERS-CoV, led by my colleague, Dr. Mohammed Shahrani, where a case control study of patients who were treated with ECMO and match control with patients who had similar level of hypoxemia, but were not treated with ECMO. And this observation data suggested or showed that mortality was lower in the ECMO patient, but this is an observational study. Cardiovascular management of these patients. We know from other viral infections that myocardial involvement can happen. For influenza, is well known, and in influenza, often this includes right and left ventricular dysfunction. And when patients develop myocarditis from influenza, these patients would have longer duration of vasoactive agents and mortality, and sometimes they require ECMO or other types of supportive care. So ECMO may have a place in selected group of patients with COVID-19. As the cases of COVID-19 increase, there have been also a huge increase in the number of clinical trials addressing different questions for COVID-19, which is fantastic. So, for example, there are many clinical trials that addressing antivirals like remdesivir, like different antiretroviral agents, anti-influenza agents, chloroquine and hydroxychloroquine, and others. There are studies that use biological therapies and several immunomodulators, such as interferons, corticosteroids, and anti-IL-6 and anti-IL-1 therapeutics, among other therapeutics. So we'll start with the steroids. Steroids, as I mentioned, were commonly used in COVID-19. And this is a review that looked at evidence accumulating from other viral infections, such as MERS, SARS, influenza, and RSV, and suggested that clinical evidence does not support corticosteroids for COVID-19 lung injury. We had a study in MERS patients where we demonstrated that when we adjusted for the indication for the time-dependent variables, for the indication of steroids, there was no difference in mortality, but there was a prolongation of viral shedding of the virus. However, there are studies from ARDS of heterogeneous etiologies suggested that steroids might be beneficial in severe ARDS. And that's why the Surviving Sepsis Campaign recommended that in mechanically ventilated patients with respiratory failure without ARDS, we suggest against routine use of steroids. Maybe in patients with ARDS, steroids can be used, although this recommendation, there was no agreement about this recommendation among the panel. There are multiple clinical trials being conducted as we speak now on patients with COVID-19, and hopefully this will inform this recommendation and will give us better guidance on what to do with corticosteroids. Antivirals, we just summarized recently, we just released a few days ago in Emerging Infectious Diseases. This is a systematic review of pharmacologic treatment, supportive care of Middle East of MERS-CoV, and I think might be interesting thing to look at. For COVID, the highest priority agent considered by WHO Working Group was the remdesivir, and it has in vitro activity against MERS-CoV, SARS-CoV, and Ebola. At present, there are ongoing trials in China for severe and non-severe COVID-19, and also there is a trial in the USA. So I would expect that we will know hopefully soon whether remdesivir is beneficial for COVID-19. Another agent that received a lot of discussion is lopinavir, ritonavir, and this is an HIV drug. It has limited side effects. It has been used in SARS and in observational data where 41 patients with SARS compared to 111 patients historical control, there was significant reduction in the occurrence of acute respiratory syndrome, but the study has many confounders, and it's hard to attribute this only to lopinavir, ritonavir. In vitro, there is evidence that this antiviral has a significant inhibitory effect against MERS, and that's why it received some interest for MERS-CoV. This is a study, the SARS study, where we see here on the left that patient received lopinavir, ritonavir had a reduction in the viral load, while in the patient's control group wasn't. Interestingly, there was one patient who continued to have high viral load, but this patient was on high-dose corticosteroids. There's a recent clinical trial published in New England 2 weeks ago of using lopinavir, ritonavir in COVID-19, and it showed that this treatment, when used alone, was not associated with time to clinical improvement, which was the primary outcome. It was not associated with difference in mortality or viral shedding. However, the treatment was started around 13 days from onset of symptoms to enrollment. So it was rather late treatment. So whether this study exclude completely beneficial effect of this treatment or not is to be seen. And I think earlier treatment might still have benefit. There are in vitro data that suggested that chloroquine might have benefit, and there was a news release from China suggested efficacy in patients with COVID-19, but data about this is not available. There is a study about hydroxychloroquine from China on a COVID-19 patients, 26 patients, single arm protocol. And these patients were compared with patients who were not treated, who refused the treatment. They were used as negative control. There, depending on severity, azithromycin was added, and the authors report a significant reduction in viral carriage at day 6. And this study created major interest in hydroxychloroquine. But as you could see, the evidence is really still very weak. It's observation study, many confounders, mixed treatments. The control group is not the same as the treatment group. So I think we need to be cautious about generalization of these studies. As you may know, we are conducting the Miracle trial, which is for MERS-CoV. This is a combination of lopinavir, ritonavir with interferon beta 1b. This is a study sponsored by King Abdullah International Medical Research Center, Ministry of National Guard Health Affairs. And I'd like to thank all co-investigators and participating sites, in particular my colleagues at Prince Mohammed bin Abdulaziz Hospital and other active sites who contributed hugely to the study. So far, we recorded 95 patients. Our sample size is 114, and hopefully we'll have answers that for MERS and might also be helpful for COVID-19. We published recently the observational data about ribavirin and interferon for critically ill patients on a large cohort with MERS-CoV and demonstrated that this combination of ribavirin and interferon alpha and beta 1A was not beneficial in reducing mortality or viral load among MERS patients. It is possible that the type of interferon used is important. In the observational data, mostly people use interferon alpha, while the data suggests that interferon beta has the strongest inhibition for MERS-CoV, almost 41-fold more inhibitory than interferon alpha. And the interferon beta, of course, is what we are using in Miracle and what's been used now in several trials for COVID-19. I think as people are so interested of treating patients with COVID, there have been large amount of off-label therapeutics being used for COVID-19. And that's some patients as rescue therapy might be justified, but I think we need to be cautious that the evidence for these therapies is not there, and we don't know if they may be beneficial or even harmful. And the other issue is the best track for this is to include them within a clinical trial. Another aspect which is important for this infection is to note that many of these patients have co-infection with bacteria and viruses. And there are several studies now reporting other viral infection with other coronaviruses, influenza, rhinovirus, and other bacteria, and also bacteria with COVID-19. This is similar to what we've seen with MERS. So 18% had bacterial co-infection and 5% had viral co-infection. This is also similar to what's seen in influenza. And that's why the recent 2019 ATS-IDSA clinical practice guidelines recommend standard antibacterial therapy to patients with community-acquired pneumonia. And similarly, the Surviving Sepsis Campaign recommended starting empiric antibiotic and then de-escalating based on further microbiologic and virological data. So at present, there are lots of things we know about COVID-19, but also there are many unanswered questions regarding this infection. And the way forward in addressing these questions is to test them in randomized controlled trials. The usual traditional approach is to do a randomized controlled trial that addresses one single question and then focus on this question, get an answer, and then when you finish, you go to the next question and third question. So for example, we'll do a clinical trial on antiviral, we'll get an answer, we'll do an interferon trial, we'll do a steroid trial serially, which means that there's a lot of resources and a lot of time will be needed to answer these important questions. There are a new model for doing clinical trials. It's called REMAP, Randomized Embedded Multifactorial Adaptive Design, REMAP-CAP trial, where multiple interventions are being tested at the same time and looking at certain outcomes. This will improve the efficiency and use adaptive design and Bayesian analysis to readjust the intervention and sample size and the randomization ratio among these interventions. So for example, this is how it's proposed. Patients with confirmed or suspected COVID will be randomized simultaneously to multiple modules of randomizations, and they can receive or not receive certain therapies. So they may receive certain antiviral, may or may not receive steroids, may or may not receive macrolide, may or may not receive immunomodulator based on the randomization. So there will be combination, and with using large sample size, this allows to answer multiple questions at the same time. So in conclusion of this presentation, it is very important for us at hospital level to be prepared. I think I mentioned that this is an infection that has a tendency to cause nosocomial infection. So we need to prepare from infection control standpoint. We need to be prepared also from surge capacity, because in other countries where a large number of cases presented to ICUs overwhelm the current capacity, and therefore we need to put in place plans to be able to respond and manage all these flux of cases. This include the proper triage of patients from the point of entry to the healthcare system until they manage in the ward or in the ICU. So, for example, the patient with respiratory symptoms should be triaged separately from the emergency room and be managed probably in separate ward and separate ICU preferably. As at the level of physicians and nurses and doctors and RTs, we need to be familiar with case definition, and we should be updated. I showed you the most updated case definition by the Saudi CDC, which put low threshold to test for SARS-CoV-2. Any patients with severe pneumonia admitted to the hospital, whether it's community acquired or nosocomial acquired, should be tested for SARS-CoV-2. It is critical that we comply with infection control precautions while we are managing patients in the ICU and in the hospital. It is our responsibility towards our patient to avoid spread of infection from one patient to the other. It is our responsibility, of course, to avoid the transmission to ourselves and to our families. So strict compliance is the key. We need to be aware of the diagnostic testing and the pluses and minuses and the shortcoming of certain tests. We need to recognize that supportive care is the mainstay of therapy, and it depends on how we provide the supportive care, how we adhere to best practices, the outcome of patient may be affected. And the surviving sepsis guidelines provide a very good guidance for proper management, ventilation, hemodynamics, and these documents will be updated regularly. At present, there is no evidence for effectiveness of any antiviral therapy, and they are not recommended routinely in current practice guidelines. I think we are waiting for more convincing evidence for efficacy of antivirals before they will make it to clinical practice guidelines and become standard of care. With this, I like to thank you very much for listening, and to thank the Saudi Commission for Health Specialties for giving me this opportunity, and also for taking the lead in spreading the knowledge about COVID-19. Obviously, the amount of knowledge is changing all the time for this infection. So it is important that we remain updated about this infection and how it's managed. Thank you very much.
I see several questions sent to me by Dr. Sami from the chat. There are lots of great questions. We're going to select a few from these questions. So one question is there reality for COVID patient having hypoxic condition, which meaning mentally alert with low oxygen saturation, with treatment advised as self-proning or assist proning in intubated patients? There is a recent editorial written by Gattinoni 2 days ago, suggesting that there are two forms or two phenotypes of patients with lung involvement. One has limited lung pathology but hypoxic, and another, and this type where the lung doesn't have a lot of infiltrate, would not respond to PEEP and a lot of ventilatory maneuvers. Another type has a lot of infiltrate, typical ARDS, and this is recruitable. So just the point is that there are lots of things we don't know about this disease. So it is possible that there are different type of or phenotypes of this infection with different presentations. The question about self-proning in non-intubated patient or in intubated patient. Of course, we know the data about proning in ventilated patients from randomized controlled trials. And there's also some case reports about proning of non-ventilated patient. And I think it's an interesting area to consider. But at this point, I think we should follow the standard approaches for managing hypoxic patients. Second question is there a role for fresh frozen plasma from recovered patients with corona? This is called convalescent plasma. So plasma taken from people who recovered from infection to treat them. So this has always been an interest to treat viral infections. We had the same interest in MERS, but it was in MERS, patient who recovered had relatively low titers of antibodies, so really did not work out for MERS. But for COVID, there's a lot of interest in this. There are several cases reported recently in JAMA, but it's not a randomized controlled trial. There are several research projects ongoing on the use of convalescent plasma. So hopefully we'll learn more about this. But at this point of time, it's not recommended as part of standard therapy outside the research protocol. There were a couple of questions about diagnostic test and negative test. Negative test is mainly related to the amount of virus in the secretions, and it's related to the quality of sample and how long it took to run the sample. So yes, some of the samples can be negative when the patient actually has COVID. And this is very similar to what we saw in MERS. It happens in many viruses. Generally, lower respiratory samples in patients who have pneumonia have higher positivity than the upper respiratory samples. So if there is a clinical suspicion, we should repeat it. And you don't need to wait a lot. You could just repeat it. Once the results are negative, you could repeat it if you are still suspecting infection. There is a question about whether open versus percutaneous tracheostomy is better in COVID patients. Good question. I think, I don't know if anybody knows the answer, but both interventions need to be conducted under precautions and with avoidance of the splash of air. So if it's done correctly and without a lot of aerosol generation, probably they will be similar, but it's hard to tell which one is more infectious. Obviously, when we do tracheostomy, we do it days after the onset or admission to ICU. And hopefully by that time, the infectivity will be less. But I think we should continue to take all precautions possible.
الله يعطيك العافية. Thank you so much دكتور ياسين. And I will بس حبيت أأكد يا أخوان التسجيل الكل سجل عند الحضور للويبينار. صفحة التسجيل أخذنا معلوماتكم، حتحتاج لها بعض الوقت عشان نسوي لها نتأكد من اللي كمل الندوة معانا، وبالتالي حيدخل في حساباتكم كساعات تعليم مستمر. نعلن الإعلان الندوة القادمة نراكم فيها بإذن الله يوم 7 أبريل يوم الثلاثاء، اللي تكون بعنوان Preparing Your Emergency Department for the COVID-19 Pandemic. What's the next steps? It's going to be presented by Dr. Abdelaziz Al-Rajihi, the chairman and the consultant in emergency medicine in King Faisal Specialist Hospital, and Dr. Muhammad Al-Hilayil, emergency medicine consultant and the chairman of emergency department King Abdelaziz Medical City. إلى ذاك الوقت نراكم على خير إن شاء الله.